today with Dr. Ahkeel Allen, who is a breast surgical oncologist out of the Breast Care Center of Miami. Thank you for sitting here with us today.
Thank you. Thank you for having me.
So we're super excited we have lots of questions for you surrounding breast cancer. A lot of people don't know about breast health, so that is what you are here for, the expert. So tell us a little about yourself.
So me, I'm a breast surgical oncologist, as you said. This is someone that specializes in the care, specifically the surgical care of breast cancer. And originally I'm from Jamaica. I grew up in Florida. And our practice, Breast Care Center Miami, is here in Miami, and we serve the greater South Florida community.
So what types of surgery do you do, and what impact do those surgeries have on the outcome of the cancer?
I see. Very good question. So for someone with breast cancer, there are two major options for surgery to the breast. One would be to remove the tumor and conserve the breast itself. This is a lumpectomy. Breast conservation surgery is another term for this. And the second option is a mastectomy, removing the entirety of the breast tissue while preserving, a lot of times, the majority of the skin, and in certain cases, the nipple itself. As far as surgery to the breast, the good news is that either of these choices, survival, you being alive 20, 50 years from now, is comparable. They're equal. So, there's a lot of choice and kind of personal touch in making this decision. But I'm lucky to say that I do offer both lumpectomies, mastectomies. I work closely with local plastic/reconstructive surgeons in mastectomies with preservation of the nipple and things like that, starting the reconstructive process at the same time of your initial surgery. Regarding the surgical options for the treatment of breast cancer, we have come a very long way. Previously you would have a mastectomy for all tumors, meaning removing the entirety of the skin, the entirety of the breast tissue as well as the nipple itself. However, now we're able to save the nipple areolar complex and you can begin the reconstructive process at the same time as your original surgery. Additionally, for lumpectomy, breast conservation, saving the breast, this is no longer disfiguring. We have special techniques where we hide the scar. We have special techniques to rebuild the breast mound to allow for an even lay of the skin itself. So, we've come a very long way in both the surgical aspects as well as the medical aspects regarding care. Surgery for breast cancer also involves surgery to the lymph nodes. These are the lymph nodes under your arm, the axilla, and this is something that is changing as well. Once again, we've learned over the years that doing less maybe actually be just as good as what we did before, doing more. So limiting the amount of surgery to the axilla is where we are as far as that regard.
I think it's very encouraging, especially to a lot of women who are scared about that disfigurement from surgery or having breast cancer. So I think it's very encouraging to know that that's not the case. You can go on living a normal life as long as you're being healthy and taking care of yourself. So what screening guidelines are there? Do you have any recommendations?
Yes. So another important question, this being Breast Cancer Awareness Month, October, screening is very important. This is how we find the majority of tumors, luckily nowadays. With that being said, also corona concerns, so nationally we've seen the numbers of screening that this has gone down. With corona, patients are homebound and a lot of them are afraid to venture out to move forward with screening. It's similar to colon cancer that we're seeing less screening. So we expect in the future that, the number of more advanced cases may increase once everyone gets caught up. So I'd like to just encourage everyone to move forward with screening. As far as screening for breast cancer, this can be a very controversial topic. And I mentioned already once that, this is the era of personalized care. So with that being said, there are lots of different organizations regarding screening. To name a few, the U.S. Preventative Services Task Force, they call for screening at the age of 50. The majority of other individual societies, they call for screening at a younger age, but ultimately will depend on your personal history as well as your family history of breast cancer. So for example, someone who has no family history of breast cancer, then their lifetime risk, they're at average risk of developing malignancy, you may consider initiating screening at 40 years old. For someone who has a strong family history of breast cancer, multiple relatives at an early age, you may consider initiating screening at a younger age, at 30 years old, to, just as a brief example. So it really will depend on the patient themselves and on a case-by-case basis to discuss this with your healthcare provider. When would be the best time to initiate breast screening? That's one part of it. Additionally, how frequent should we be screening is another question. And lastly, the type of breast screening, this makes a big difference.
You talked about family history being a guideline for some of the screening processes that we need to be aware of. I think a lot of people forget that men are just as susceptible to breast cancer as women. So is there a difference in family history as far as a man being screened versus a woman?
Excellent question. And specifically, there's not a set guideline for screening in men. However, unfortunately, about 1% of breast cancer, does affect men. So I do encourage males with a strong family history of breast cancer to be aware of their breast. You have breast as a male. There is breast tissue that's there. So, whether it's doing a self breast exam, to yourself once a month, similar to what we recommend with women, I would recommend that for men with a strong family history. Additionally, one thing we touched on, we mentioned family history. Going along with that point is genetic testing. So some patients, those who have a strong family history of breast cancer and other malignancies. So, as far as meeting the criteria for genetic testing, if you have any family member with ovarian cancer, for example, or any family member with metastatic, this is cancer that has spread somewhere else, pancreatic cancer, you yourself can be tested genetically to see if there is in fact a gene that we're aware of that is passed down through your family line to show us that, yes, you are at increased risk. Because if that is the case, our recommendations would change.
So you talk about genetic testing. So if a genetic test came up and said that you are genetically predisposed to have breast cancer, do you necessarily recommend a mastectomy, or is that a personal choice?
That will be a personal choice. So once again, very excellent question. There are differences in the genes as far as the amount of risk that one may carry. For example, the most common gene that we know of is BRCA, and there are two variants, BRCA1 and BRCA2. And with that, this could be a lifetime risk of up to 85% of developing a breast cancer. Whereas there are other genes, ATM to name one, that puts you at a lesser risk as far as your lifetime. But everyone will have the choice of, undergoing prophylactic surgery before actually having developed a breast cancer in order to prevent that from happening in the future. And with every gene mutation, there's multiple organ systems that we have to consider. So luckily here at Breast Care Center Miami, we do offer genetic counseling and testing. And this is part of the advances in cancer care that we have seen. One thing that I mentioned previously was the type of screening, and screening saves lives. I mean, honestly, this is how we detect early disease, and with early stage disease, we're seeing upwards of 93 to 97% cure rates. And I'll say that again, upwards of 97% cure rates, 5-year survival rate with early stage disease. So once again, it being Breast Cancer Awareness Month, it's important to be screened. The different modalities of screening would be a mammogram, an ultrasound, and the breast MRI for our high-risk patients, those with a strong family history.
So when you talk about family history, how close in the family line does a relative need to be that would cause concern for breast cancer?
They have different degrees of relatives. So a first degree relative would be someone, for example, a brother, a sister, a mother, someone who's only one step apart. But, anytime you have multiple relatives, regardless of the degree, it being two steps apart, a cousin, an aunt, something like that. If there are multiple family members, it's important to consider genetic counseling and testing, and you are considered higher risk with multiple members. Previously, I mentioned additional types of tumors, ovarian cancer, for example. It doesn't matter the degree of the relative, metastatic pancreatic cancer, metastatic prostate cancer, for example. It really makes a difference. So in general, I would recommend just seeking counseling from your provider, your medical provider, in regards to genetic counseling and testing, as well as in regards to your risk of developing a malignancy in the future.
Okay. You also had talked about self-examining as a way to kind of pre-screen before you go to see your provider. What does self-screening look like?
So a self breast exam, what I recommend is, what I recommend is breast awareness. So this would involve kind of selecting a scheduled day of the month. For me, I would say the first of the month, every time the calendar changes, hey, it's time to examine my breast. And, there are two ways to do this. And I would recommend kind of two ways. One, while standing, a lot of patients may do this in the shower. And then again, while laying down, at night, you examine your breast. And, if my palm is your breast, for example, you should just kind of systematically go up and down all the way through to make sure you cover the entirety of your breast. Things change. There are lots of patients with non-malignant disease of the breast. You're in response to your hormones, you may have, pain that is cyclic, or a lump that you may be aware of, and that changes. But if there are any positive findings, anything that you feel that is just not exactly comfortable, it could just be discomfort, you should bring that to the attention of a medical provider.
So, I think a lot of people assume as well that they would automatically have some type of pain associated with a lump. Is that necessarily the case?
That is not necessarily true. Most often, malignant tumors are not tender, they're not painful. So this all goes back to screening. Most often we detect these tumors before there's there's something that you can feel.
So a lot of people talk about deodorants with the aluminum in them, and that can cause breast cancer. Is that true?
So regarding aluminum and deodorant, there are several different things that increase your risk of breast cancer. Number one is family history and genetics, as I mentioned previously, but really your estrogen exposure is the number one cause and increased risk of breast cancer. So there are things that information we gather from you when you see us, to include the age at which you started, your menstrual period, for example, the age of your first child, things like that, to help us to judge your overall lifetime estrogen exposure. Interestingly enough, recently in the media, there are other things such as alcohol intake. Your daily alcohol intake is another factor. Secondly, hair dye. There's a study that came out that mentioned permanent hair dye and straightening chemicals can have an effect of increasing your risk of breast cancer. But specifically aluminum deodorants, not necessarily. The research has kind of been up and down. So I would suggest if someone, is sensitive to types of deodorant products to consider one that's hypoallergenic and one that does not include aluminum. But there's no specific findings that show that it increases your risk. I think my overall message is one of encouragement. We've come a very long way in the treatment of breast cancer. It involves multimodal care, lots of different physicians working together. But overall, the survival rates with everything that we have learned has increased greatly. This is no longer something that should be stigmatized. This is something that we can take care of. And I'd like, once again, with the Corona, the COVID-19 pandemic, just kind of encourage patients to still, don't forget your screening. It's that time. It's important. This is how we capture this disease and take care of it. So, get out there and get going with screening.
I absolutely agree. Thank you so much, Dr. Allen. I think a lot of people are kind of, like you said, homebound because of this whole pandemic, and it is definitely restricting people going and getting tested and screened as they should regularly. So thank you for bringing awareness to that. I think that almost everybody I know has had some type of, run-in with breast cancer, whether it be a family member or themselves. So awareness is super, super important. So again, thank you so much for taking the time to sit down with us.
No, thank you. Thank you for having me. I appreciate it.